Why do we continue to treat it with such a one-directional facet of mechanical approach? We just talked about how the brain is so complex. Why not feed into that system with complex treatments too? So I really like these two slides. Getting into these multiple considerations of, we have a neurological component, we have a muscle or joint component too, and what we think we're doing with these tools is really targeting into this neurological component, triggering that sensory system through these interoreceptors, mechanical receptors, free nerve endings, to feed back to the brain, to kick back to that muscle, joint, soft tissue, and tell it what to do. Decreasing that pain, mitigating that pain, feeding that system. Does that make sense? Mm-hmm. So this, forget that cool little pointer. I love pointers. So this little area right here is where we think the IASTM tools, tape, all that fun stuff, ART, doesn't matter what you use, all that treatment should be located in that little triangle area. So moving into these mechanical effects, I love CT scans and MRIs. I have 43 different broken bones, or through my life, 43-ish.
We're trying to slow that down.
A lot of them didn't have X-rays or
Prove
diagnosis.
it. Prove it.
If you can't breathe and you're peeing blood, you probably cracked a couple ribs. You should probably get your spleen checked out. So, but no, I like looking at this stuff, especially for guys like Joe and I. These tiny little chicken leg calves really resonates well with me. But if we start going after these mechanical effects, there's a slide later. It's just a one-directional linear approach to trying to treat the system, which, once you get back to the top here, starts not right there in that brain. So if we are treating it mechanically, not targeting the brain, we're losing ground. So brings us to this. Samuel L. Jackson said it best with a couple expletives. We're trying to say release again. I dare you with a little MF in there. But the concept of targeting these little gremlins of these adhesions within the muscles or fascia and all these things is just not being proven right in research. If you think of, fold your hands together. Do this is fun. Fold your hands together. If we think there's adhesions that can't break our hands apart, we're wrong. Muscles are supposed to contract all the way and relax, not to the point of separation and tearing. But there's no adhesions within there that prevent that. Your brain locks that down, just like the hamstring example, and says, I'm going to be tight, or tight with quotations around it, and create a adhesion with quotations around it to impart stability to our system to protect us. So we're trying to get away from and encourage you to get away from saying adhesions or release. Shut that up. Awesome. So Robert Schleich kind of debunked this idea of fascial release, the mechanical deformation of fascia, and it really gets after the toughness of the fascia. So if it's super, super, super tough, how can it also have adhesions, is my takeaway from this. If it's supposed to be this tissue within our body that's so strong, so adaptive, has so many sensory systems, blah, 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 why would it ever have adhesions in it? Kind of going off that, it concludes that it takes 2,000 pounds per square inch to get these adhesions to break or to mechanically change tissue. So do you think you can produce 2,000 pounds per square inch with your hands, tools, tape, etc.? You might if you're really strong, but chances are you're only going to be able to do it once to your patient, because then they're going to bleed, break, do something, run out your door screaming and crying. So getting after later, we'll talk about the sympathetic and parasympathetic pathways. If we're talking to our patients, treating our patients, and they're wincing in pain, are we hitting the sympathetic pathway or the parasympathetic pathway? We want to get them calm, cool, relaxed in our offices, not screaming, crying, kicking, punching, anything like that. If we're producing 2,000 pounds per square inch, we're definitely hitting that sympathetic pathway and scaring the shit out of them. So don't do that. Fair? Yeah. So that goes to the old school approach. Gua Sha kind of started with this, where more is more. If some is good, more is better. Getting into bruising, things like that, we don't need that. What we're trying to implement with these tools today and through every kind of utensil that RockTape has is less is more. You'll hear us say that way too many times, awkwardly the amount of times today, but it's very true. We don't need this aggressive and intense manual therapy with no regard for the system. If the brain perceives pain, it's going to protect itself. If we are inducing pain to the body part in the patient, it's going to protect itself. Make sense? So getting after these neurological effects is awesome. This drawing, I don't know how many slides you have to click through to get the full thing. You guys can tell it's a brain and a brain stem and the spinal cord, okay? We have two parts of our brain, the reptilian brain, the old brain, which controls things like sleep, breathing when it's passive. You don't think about breathing when you're sleeping, eating and digestion, things like that. Whereas we have the neocortex, which controls pain, happiness, sadness, all those kind of fun things, really our day-to-day cognitive thinking. So down through the system, we have all these spinal cords. There's a bunch of clicks through to get all of these, all the way down to our little pinky toes. And then our skin, awesome, we're there. So this is what we're affecting with the tools, with the tape, with our hands, with screening processes, with everything, is the skin, right? Even, I would extend that to all the senses that we have, smell, touch, hearing, vision, all those kind of things, where we're affecting the sensory system to get into these nerves, into the brainstem, bypass that reptilian brain, get into that neocortex, which then controls pain, happiness, sadness, affect, everything. So that's kind of our pathway that we're going to be talking about today. Shoot. When you accidentally hit the wrong button, and then you got to go through all the nerves all over again.
It's not your fault, Steve's fault.
Steve's fault. This drawing was written very well by Steve Capobianco. He's very proud of it. It was modified from Diane Jacobs' reading of dermal neuromodulation. But then we get into Hilton's law, where it's a good branch off of that, good pun, branch off of that last slide, where Hilton's law is the same nerves that supply our muscles also supply the skin to that area. So if we're talking about the knee joint, we get the quadriceps that cross over that, anterior tib, maybe gastroc hamstrings, that whole complex. All the nerves that supply my quad also have branches that split off and supply the skin nervous sensation to that area. Does that make sense? Have you guys heard of that before?
Mm-hmm.
No?
Yes.
Okay. Which brings me to the body maps, and if we can improve the perception of our body and the awareness and proprioception is what I kind of take away from this most of all. That's kind of to deal with what kind of athletes I see. If we can improve the proprioception and perception of our body awareness, we can improve our pain mitigation, decrease pain even, as well as bring up tactile acuity to that area. When we're driving down a road and we lose our GPS signal because everybody and their mother is using it at that time, I say GPS signal, nobody has a TomTom anymore, I would hope. Anybody have like one of those little Garmin systems in their car? The one built into your car?
Oh, no.
Okay, yeah, like the external one. My
Yeah.
parents still use it, and I make fun of them all the time. You have that on your phone, you know. When you're using your phone, it's rush hour, and everybody's on it. Do you notice that your phone kind of slows down? Especially like when you're right about to take your exit. And it's like, oh shit, I need it. It needs to work. I did that on the way in this morning. Luckily I know the area. But it seems that every time you need your phone most for GPS or directions, the signal gets lost. We get this faulty map, and then we have no clue where to go. Pain in your body is kind of the same way. If we have a faulty part, sprained ankle for example, and your body doesn't really know what to do with it, it fills that blank in with pain. So me driving in this morning, let's pretend I didn't know the area at all. If I missed, what's the exit off of? Marion Kellogg. I just remember Kellogg, because that's what that was off of. So if I missed Marion Kellogg, my brain would say, oh shit, and panic would ensue. Whereas in your body, it says, OS, pain is going to ensue. Does that make sense?
Mm-hmm.
So that's kind of what this slide talks about. My big point on this is the body map is one's self-representation of yourself in one's own brain. That's kind of confusing. If representation is accurate, movement is good. If movement is good, my add-on to this, pain decreases. Is that fair to say? My big thing when I talk to my patients, and I swear a lot, I'm sorry, I'm trying to fix this. I have a 2-month-old, so I'm really trying to fix this. If you move like shit, you're probably gonna feel like shit. If I see a runner whose knee is crashing in like this, he might not hurt for a 5K, but you put him out to the Tahoe 205 that just ran last weekend, The Tahoe 205 mile. Was that last weekend? The days fly by.
Can you imagine?
What's that?
It's a long day.
That's a long. What did Courtney DeWalter finish
It
at?
better be more than a banana at the finish line.
Some people finish at like 20, 30 hours. It's insane.
won't
But
be
if you go
200
and run
miles
that
on the
205 miles, your knee is probably gonna hurt. So if you're moving like crap, eventually you're gonna feel like crap. So if you start representing your body a little bit better, movement gets better and pain decreases. Then we can get into precision training with